Let's jump right into high-yield Step 2 CK decision logic for pulmonary obstructive diseases. We're bypassing the basic science here and targeting those crucial next best step algorithms. Our main goal today is strictly focusing on how to definitively separate these pathologies, and more importantly, how to manage them correctly on test day.
Section 1. Sorting wheeze and acute bronchitis. Before we even think about diagnosing chronic diseases like asthma or COPD, we have to establish the differential diagnosis for a wheezing patient. We need to efficiently separate out things like acute bronchitis, congestive heart failure, pneumonia, anaphylaxis, vocal cord dysfunction, and pulmonary embolism.
Let's start with acute bronchitis. This typically follows a viral upper respiratory infection. Your patient is going to present with a cough that's been hanging around for days, maybe even weeks. They might even have purulent sputum, but, and here's the key, they will completely lack systemic pneumonia findings like fever or chills. Because 90% of these cases are viral, your treatment is purely symptomatic. Think NSAIDs or bronchodilators. Absolutely do not give them antibiotics.
Now, what if a patient presents with sudden exertional dyspnea and wheezing? The arterial blood gas is your best friend here. It definitively splits the differential. Congestive heart failure causes pulmonary edema, which triggers tachypnea. The patient blows off CO2 and boom, you get a respiratory alkalosis. On the flip side, an acute COPD exacerbation causes severe air trapping and CO2 retention, which creates a respiratory acidosis. So, simply put, high CO2 points you towards COPD, while low CO2 points right to CHF.
Moving to Section 2, diagnosing asthma versus COPD.
Both asthma and COPD are obstructive, meaning they both feature a forced expiratory volume in 1 second to forced vital capacity ratio, the FEV1 to FVC ratio, below 70%. You'll want to recognize that classic scooped-out appearance on the expiratory flow volume curve. That scoop is the hallmark of obstruction and tells you the patient is having a really hard time getting air out of their lungs.
So how do we tell them apart? The diffusion capacity of the lung for carbon monoxide, or DLCO, along with bronchodilator reversibility, are how you contrast these two pathologies. Asthma features a normal or even high DLCO, and it shows significant reversibility. We're talking at least a 12% and 200 milliliter increase in FEV1 after giving a bronchodilator. COPD, on the other hand, typically has a reduced DLCO, especially if emphysema is present due to alveolar destruction, and it's only partially reversible, if at all.
When looking at the physical exam and chest x-ray for COPD, you're hunting for signs of hyperinflation. You'll see more than 10 posterior ribs, a flattened diaphragm, a narrow vertical cardiac silhouette, and you'll hear distant heart sounds. But here is an absolutely crucial exam rule. Digital clubbing is never, ever caused by COPD itself. If you see digital clubbing in a COPD patient, you must immediately search for an alternate cause, like an occult lung malignancy, bronchiectasis, a lung abscess, or an empyema.
For suspected asthma with intermittent symptoms, your next best step is to start with spirometry. Finding obstruction with bronchodilator reversibility confirms the asthma diagnosis. But what if the baseline spirometer is normal, yet your clinical suspicion is still high? That's when you use a methacholine bronchoprovocation test to assess for bronchial hyperresponsiveness. If the obstruction is non-reversible or the methacholine test is negative, you need to seek an alternate diagnosis. Keep in mind, GERD can actually worsen asthma through increased vagal tone, bronchial reactivity, and microaspiration. Also, don't forget that anaphylaxis can totally mimic asthma if you happen to miss concurrent skin or GI clues.
Section 3. Stable COPD and oxygen therapy.
Managing stable COPD is all about scaling therapy based on symptoms and exacerbation history. For Group A patients, those with low symptoms and few exacerbations, you just use short-acting agents like a short-acting muscarinic antagonist on an as-needed basis. As symptom burden and exacerbation risk climb into Groups B and E, you escalate. You'll want to use a long-acting muscarinic antagonist plus a long-acting beta agonist. Now, what about inhaled corticosteroids? You only consider adding those if peripheral blood eosinophilia is present, but you definitely avoid them if the patient's risk of recurrent pneumonia dominates the clinical picture. You absolutely need to memorize the exact thresholds for long-term home oxygen therapy because, alongside smoking cessation, it actively improves survival in COPD patients. The standard threshold is a resting PO2 of 55 millimeters of mercury or less, or an oxygen saturation of 88% or less on room air. But for patients with signs of right heart strain, like cor pulmonale or right heart failure,
or polycythemia with a hematocrit above 55%, that threshold actually adjusts. For them, you start oxygen at a PO2 of 59 or less, or a saturation of 89% or less.
Section 4. Acute COPD exacerbation management.
Acute COPD exacerbations are typically triggered by things like respiratory viruses, bacteria, a pulmonary embolism, or sterile inflammation. The cardinal symptoms you're looking for are increased dyspnea, increased sputum volume, and increased sputum purulence. To manage this, you want to maximize expiratory flow using inhaled bronchodilators and reduce airway inflammation using systemic, not inhaled, glucocorticoids. Also, you must maintain an exact oxygen saturation target of 88 to 92%. Pushing their oxygen higher than that is dangerous. It worsens hypercapnia by increasing alveolar dead space ventilation.
The decision logic for prescribing antibiotics during a COPD exacerbation is very specific. You only give antibiotics when increased sputum purulence is present alongside at least one other cardinal symptom, so either increased dyspnea or increased sputum volume. The only other absolute indication for antibiotics is if the patient requires mechanical ventilation, whether that's non-invasive or invasive.
If the exacerbation results in respiratory failure, your immediate next step is to begin non-invasive positive pressure ventilation, or NIPPV, assuming there are no contraindications. However, you need to proceed directly to endotracheal intubation if the patient fails a trial of NIPPV or if they present with profound acidemia, meaning a pH under 7.1, poor mental status, or hemodynamic instability.
Section 5. Severe and occupational asthma.
Status asthmatics is a life-threatening emergency that requires a rapid escalation protocol. You start aggressively with nebulized short-acting bronchodilators, specifically albuterol plus ipratropium, along with systemic glucocorticoids. If the patient has a poor response to that initial therapy, you add intravenous magnesium sulfate. Throughout this process, you have to monitor them incredibly closely for any signs of impending respiratory failure that would ultimately require intubation.
So what are those clues for impending respiratory failure? You're looking for a silent chest on auscultation, altered mental status, and severe accessory muscle use. Crucially, if you see a normal or elevated PaCO2 in a patient with a high work of breathing, that's a huge red flag. It indicates respiratory muscle fatigue and a total inability to maintain hyperventilation. That patient requires immediate mechanical ventilation.
When managing severe asthma exacerbations in pregnant patients, you follow a very similar treatment flow: albuterol, ipratropium, and systemic glucocorticoids. However, there's one major exception. Epinephrine is strictly avoided due to its vasoconstrictive effects on the placental circulation. You also need to adjust your oxygen goal. You must maintain a saturation of at least 95% to ensure the fetus is getting adequate oxygen.
Diagnosing occupational asthma is a two-step process. First, you have to confirm baseline asthma using spirometry or methacholine bronchoprovocation. Once that's established, you need to demonstrate workplace-specific worsening. You do this by having the patient record serial peak expiratory flow rates both at home and at work. A decline of greater than 20% in their peak flow while they are at the workplace is what definitively confirms the diagnosis.
Section 6. Smoking cessation pharmacotherapy.
Let's wrap up with the algorithmic management of smoking cessation. Your first-line pharmacotherapy options are varenicline and nicotine replacement therapy. Now, bupropion is another solid option, and it's particularly useful if the patient has underlying depression or major concerns about gaining weight after quitting. However, bupropion lowers the seizure threshold, so it is strictly contraindicated in any patient with a history of seizures or an eating disorder like anorexia or bulimia.
Finally, you have to remember that smoking cessation is the single most definitive intervention to actually improve mortality and delay disease progression in COPD. For patients scheduled for elective surgery, quitting just a few days prior won't cut it. Cessation must be initiated more than 4 to 8 weeks prior to the procedure. Stopping more than a month out is what significantly prevents post-operative pulmonary complications like atelectasis and bronchospasm.